Welcome to Fuller Butz, a behind-the-scenes plastic surgery podcast. Yes, you heard that right. Join your co-hosts, Dr. Sam Fuller and Dr. Dan Butz, board-certified plastic and reconstructive surgeons, on an exclusive full-access pass into the world of plastic surgery. Combining their expertise and training, Drs. Fuller and Butz will share medical insights, detailed explanations, and lighthearted humor to keep you entertained and informed. We're certain you'll become passionate about the plastic surgery specialty, and between debunking myths, uncovering truths, or just making you laugh out loud at their perspective on this creative and artistic field, we've got something for everyone. From tummy tucks to Botox and mommy makeovers to surgery do-overs, the Fuller Butz podcast will surely satisfy your podcast fix. All right, now let's dive into this episode.
Hey everybody, welcome back to the Fuller Butz podcast, a behind-the-scene look at plastic surgery. I'm Dr. Daniel Butz. I'm with my co-host, Dr. Sam Fuller, both board-certified plastic surgeons. How have you been, Sam?
Doing great. Busy. Families are doing well and playing hockey and celebrating birthdays and itching for warmer weather into summer where we're not on again, off again with rain and snow. How are things over in Milwaukee?
Same. Basketball season's wrapping up. Now soccer and soon to be lacrosse is a new sport the kids are trialing this year.
That's awesome.
I've never really played lacrosse once, actually, like in 6th grade, and someone broke my tooth. That was fun. Your kids are skating, all of them?
2 are doing learn to skate. So they basically have like a 25-minute tutorial, and the oldest is in a full ice hockey, like geared up mouth guard and helmet.
Yeah.
And it takes like 17 minutes to get him all, ready to go. And
That's gotta be amazing.
Yeah, I can't tie his shoe, but he can play ice hockey.
Right.
So, yeah, it's fun.
It's awesome. I think today we were going to dive in, try to give a little just kind of overview of what a typical OR day looks like for a patient, coming in. Sometimes it's a really intimidating, kind of nerve-wracking experience, and something we often take for granted that this is what we do every day. But we thought this would be helpful just to kind of lay the groundwork give some understanding of how that might look like for their experience. So I don't know if you want to kind of go over the first things that someone should expect the morning of surgery and what they should kind of plan for.
Yeah, our goal is to roll back the curtain, so to speak, so everyone's just feeling more aware, more comfortable with what plastic surgery is. And so we've talked about procedures and topics and problems, and really the OR day is anxiety provoking. And I think it's normal in human nature to be anxious. In my private pre-op room, I jokingly have called it the panic room for the last couple of weeks because I can sort of see it in their eyes. And having, my wife who had a C-section, I know what it's like to be on the other side and being nervous and, not being entirely in control. And whether it's the anesthesia, whether it's the surgical, it's very rational and healthy to have some nerves. But hopefully this podcast can shed some light on the expectations for that day. So surgery day is upon us. These are typically early start days. If I have a 7 a.m. start, usually the patients are rolling in through registration around 5:30. That requires documentation, ID, filling out paperwork that's everywhere in the world, and then being ushered into a private room where they're changing into a gown and having an IV placed by the preoperative nurse who also reviews their health problems and the last time they ate or drank, and make sure that they don't have any piercings and other items that are not allowed for surgery. Dan, any other pre-op visuals for our listeners?
They routinely want a pregnancy test as well, right? So I often encourage them to try not to go to the bathroom right when they wake up to make sure they have a full bladder, so we don't have to be waiting on that. That's the only other real big thing. Your early mornings, can't have your coffee, and getting everything ready. And then the next step is, typically once you get that IV in, is I'll try to, get in there next and mark the patients. Patients are always like, oh, am I going to see you again before the surgery? Like, absolutely. We're going to, after you go through all that process, we're going to review everything, do all the markings, measurements, making sure, when you're standing up, things are going to look how we want them when you're laying down, verifying the implant size. It's pretty unusual to make any last minute changes, but sometimes people get, nerves right beforehand and want to go up or down a little bit. And just making sure we're all, really on the same page for that and have a good roadmap or kind of plan for the surgery. So what do you do anything special during markings? Lots of measurements.
In my pre-op office
visit, 6 different color Sharpies.
No, I do encourage them not to put any lotion moisturizers on their skin the night before the day of, just because everything gets smeared all over. But otherwise, I have one color. I have my measuring tape, always measure twice, cut once. And so measuring quite a bit, trying to just decrease some of the nerves, answer any last minute questions, and making sure that we're on the same page. When available, my nurse practitioner is in the room with me, just because she's usually calling the patients the next day, and she can introduce herself and be a common voice as part of the team that's going to be taking care of them. And so, I usually show up about 30 minutes before the scheduled time to do the markings and talk with the family member and encourage them to relax and, just get everybody excited and less nervous for the surgery. Anesthesia would then come into the room, as well as the circulating nurses, to go through their spiel. And I know anesthesia is a topic that we've covered before, and always something that can create some anxiousness. I've had several patients recently who've never had any surgeries before, and so it was really the anesthesia portion that was the most nerve-wracking. Dan, do you want to comment on a brief overview of what common anesthesia pre-op discussions are, or what's the most common anesthetic type that you utilize for the big mommy makeovers that we're doing these days?
Yeah, so if we're in the OR, probably going to be using a general anesthetic, which includes some sort of breathing tube or an LMA. So they want to make sure they're controlling the airway. Anesthesia is all about the ABCs: airway, breathing, circulation. So it's their job to keep you safe, and it's probably one of the safest places you can be, assuming you're a young, healthy, or not necessarily young, but a healthy individual. I often reassure patients that it's safer to be probably under anesthesia than driving there on the highway, especially in some of these snowy winter mornings we've had. So it's very safe. We do a lot of the preoperative stuff. Workup is all to make sure we're not overlooking that it could increase any kind of weird anesthesia complications. So fortunately, these go very smoothly. It's very well studied. And there are obviously local or IV sedations, but for 99% of what I'm doing is a general anesthetic. I guess you probably do a lot more blocks and things with hand surgery, but for your cosmetic surgery, I'm assuming it's mostly general.
Yeah, for plastics and cosmetic, it's 99% general or local. If you're doing it in the office or something, it's all or none. In hand, we can utilize blocks and regionals and sedations and stuff much more effectively. And so that in our surgery center, the patient actually walks back. So they'll walk back with their warm blankets to stay warm, because as you get further and further back into our operating room, it gets colder and colder. And then they sit back onto the table. There's monitors that are put on them to monitor their heart rate, their blood pressure, their oxygenation. And I tell them that's the last thing that they're going to remember. And then they're waking up feeling a bit groggy, looking down and saying, wow, my body looks different. And, that's when really our day starts, our work starts, and that's a team effort. And so after the patient's asleep, monitors are on. What are some things that happen for the surgery to begin safely and sterilely?
Yeah, so the anesthesia provider, obviously gets them to sleep, gets the airway secure, and then there's multiple team members in the room. We're not doing this by ourselves. It really does take a small village. So we have our circulating nurse, who's kind of responsible for preparing a lot of the tumescents and medications for the procedure, putting the local on the field. Then we have our our surgical techs, who are setting everything up, a sterile back table with all the instruments, sutures that we want. We have these surgical cards preference cards for every procedure, so they know what to pick. And, for the ones, I have a very small team. They know exactly what I want for pretty much everything. So not a lot of questions are being asked, which is great. But yeah, so once that's all done before the patient even gets in the room, so they roll in and kind of everything's ready to go. They get to sleep, and then you position. You want to make sure you're padding all the nerves and making sure nothing's kind of getting pressure on them. If you're sitting up, the arm should be secured, all of those things. And then the surgical prep needs to occur. Do you want to talk a little bit about how we prep patients to make sure it's sterile?
Yeah. And so one other add-on is that if the cases are scheduled or going to be longer than 4 hours, a urine catheter fully may be placed as well. That is placed when the patient's asleep and is removed when they're asleep as well by our circulating nurses. And that's just to not have their bladder be full of urine at the end of the case. Imagine doing a tummy tuck and then having to pee really bad, right afterwards. That's not a good feel. It's also just important for monitoring ins and outs. So how much fluid is going in, how much urine is appropriate on a hourly rate. And so that's one other add-on. But assuming that all the bony prominences are well padded, the prep starts, and that's usually the job of the circulating nurse. There's, depending on allergies and different reactivities, ChloraPrep is the prime usage, and that's a cleaning solution that kills 99.9% of surface-based bacteria, and that's done in a sterile way with sterile gloves over all of the surgical areas. That sometimes requires skin fat to be lifted up so that blue sterile towels can be placed underneath, so that if during the surgery you're trying to look around the waist to the flanks for liposuction, trying to tuck in or tighten skin from a breast reduction that's extending laterally, that you're able to keep everything in the surgical field that you want to see. The arms are typically taped and secured to the arm bores because we're sitting them up and down and want to make sure that they're secure. And then a series of drapes go across the surgical site to maintain a healthy field, so that any towels and instruments and pads are all maintained within this sterile field that the scrub nurse is maintaining throughout the process of the surgery. I usually wear multiple gloves. Sometimes I change gloves during the surgery just to make sure that they're well fit, and they're not too can become a little bit greasy or a little bit slippery. And so you want to make sure that your gown, your gloves, your mask, your headlight, your loops, everything is well fit for a wonderful transformation for the patient. Anything else I missed? Or are we ready to do a timeout, Dan?
Yeah, I mean, part of the timeout, and I guess we kind of missed this, was typically we're putting SCDs on the patient, sequential compression devices on your calves, to help make sure decrease the risk of blood clots. So those are continuously kind of pumping throughout the surgery to keep the blood moving in your lower extremities. And again, the timeout is kind of a checklist to make sure that everything is going according to plan, to kind of have these avoid these never events like wrong site surgeries, and making sure you have everything ready. So the nurse, before you can make incision, kind of goes through this checklist: patient's name, date of birth, procedure, you have antibiotics, all these different things, and everyone kind of agrees before you kind of actually get started. So that's a really important part to make sure. And this is kind of less of an issue with what we're doing, but more of an issue when doing it right or left, and it could be, there were errors made years ago.
Yeah, in our case, want to make sure we have the proper implants. We have the funnel. We have any drains that may be used. And I would say oftentimes our OR teams, I'm sure it's the case for yours, are verifying that the night before. And, they're either messaging me or making sure that that's well in position hours and days in advance of the surgery. But then a timeout is called, where there's a pause and the entire OR team listens and makes sure that everyone's on the same page, see what questions they have, verify allergies, verify correct position, and then the fun starts. We're able to perform surgery in our way of reducing pain, allowing for better outcomes. I usually inject the local numbing medicine locally first, and as well as tumescent, so that I'm not really making any incisions or cuts prior to that tissue being anesthetized, because although the patient's asleep, they can still experience pain and have that pain that is responsive in their brain waves. By blocking it from the get-go, they're not really experiencing pain, and that allows for our anesthesia providers to to give less medications that can make them nauseous or upset stomach or have any other ill effects. And so we're really trying to minimize the amount of medications, of substances that are being provided. And I'd say that's sort of a new technology is just understanding how patient care can be delivered in a safe and less invasive way. Are there any other tips or tricks or surgical setup, or do you want to talk about like what happens during a surgery? Like if you're simulating like a breast augmentation, who's with you? How does an implant come onto the sterile field and be put in a clean and safe way?
Yeah. So I think, for someone who isn't used to the OR, I remember, probably one of the first times as a med student going to the OR, it's like this foreign place. You're kind of scared. Like, what can I touch? What can I not touch? And everyone's like, don't touch anything blue. The blue drapes, the blue table, that is like, no-go zone, stay 2 feet away. And the circulator nurse is kind of the in-between for the stuff that, is in sterile containers and needs to get on the field. So they're, when you put in your sizer, you figure out what exact implant you want. You say, okay, I want 255 moderate, whatever it might be. And they say 255 moderate back to you, show it to you. You verify that's the implant you want. You never want to, open the wrong one or whatnot. And then they, again, these are specially kind of carefully packaged in a sterile way. They open it up. The scrub tech, surgical tech takes it, puts in the betadine or whatever irrigation you like to use before it's then put in the funnel. Nothing touching the implant, no technique before we place it into that pocket. And that kind of goes with any medical, any device, any extra suture, any extra local, that surgical, the OR nurse is kind of responsible for passing anything off. So in the room, there's either the anesthesiologist or CRNA kind of in charge of again the anesthesia component. Obviously, a surgeon kind of leading the surgery, and different setups can either have a surgical assistant who's kind of there helping retract, helping close in some situations. A surgical tech who's kind of more handing instruments and the sutures back and forth, and then the operating, the OR nurse. So that's kind of the core of the team. Sometimes there's additional people in and out as needed. But did I miss anybody? Is that kind of?
No, for my hand cases, X-ray techs are in the room managing the fluoroscopy. There may be reps who are bringing in equipment or making sure that it's properly being utilized, and so there's very few unnecessary staff members. Everyone has a job to do and they do it well. Dan, do you allow for music in your operating room while you're operating?
Yeah, of course. I've got
what's your beats? What's your preference?
I think I took this. I started this playlist from you because I was complaining about my playlist selection and I was having to pick something different. And you had somewhat 30-hour long playlist, and I took that and then I deleted all the Sheryl Crow. Then I just added a bunch of others. I think it's like 70 or 80 hours long now. There's really a hodgepodge of. I tend to drift towards indie rock, kind of classic rock, but I like to throw in some kind of newer music as well, kind of constantly tweaking it a little bit so you get a fun new song here and there, but nothing that's too distracting or kind of loud. You don't want that background music to just kind of help. If you're operating for 5 hours straight, you need a little bit of that kind of distraction in a sense to keep you motivated. What's your go-to? Do you still have that playlist or are you rotating?
No, I'm rotating. I would say that my OR is very low stimulus. So even the anesthesia monitors are very low beeps. The Bovie is very low beep. The suction that we use is clamped when I'm not using it. And so we could just talk at normal voices and just have a very calm environment and allow everyone to speak. And so we have Sirius XM. And so we found an interesting playlist that's like, or channel that's like 313. It's like Y2K alt stow. It's alternative from like 90s and 2000s, all the stuff that I listened to in like college and
doesn't rotate. I feel like those you'd sometimes just start getting the same songs every couple days.
Yeah, that's what we've been doing like the last 3 weeks. And so I would say that in the next week or so, we've probably heard all of those Blink-182 songs enough, and we'll probably switch to something else. So constantly mixing it up, but it's more of just background, and occasionally we'll quiz the circulating nurse as far as what year the song came out and stuff. But it's all meant to keep things moving, keep things comfortable, and ultimately ensure patient safety. For the outcomes, and any other rituals or surgery things that you do day of or before a case, as far as getting prepped and ready like an athlete would before a game?
Yeah, I mean, I think mental preparation for surgery is an important thing that if some the rhinoplasty guys I used to work with would talk about a lot. Like, you want to do the surgery 3 times. First time during the consult, the consult. Yeah. Second time, kind of before the surgery and in your mind walking through it, and the third time the actual time, and then I guess maybe those afterwards want to redo it. Yeah. So like every night I download the photos, I print them out, I look and kind of re-visualize my plan. Then when I'm there marking the patient, kind of rethink, so it's kind of all these steps that, really is important to kind of, work through that and constantly, make sure we're staying on task. So I'm like I want things to go very smoothly. I kind of have a steps in my mind that I want to kind of hit through kind of on time. And, sometimes things come up, sometimes something bleeds a little bit longer than you want it to. You got to slow down, take care of it, keep moving. But that's the biggest thing. Just kind of, I think preparation is really important. You can't go in kind of unprepared, or you're going to, get lost. What about you? What do you do?
Yeah, no, it's a huge time and game saver. Is Dr. Warner told us to do the case the night before or on the way in, do the case, and then do the case again and get better at it. And I think coupled with that is having the same team. So having the players, the teammates on your team, knowing what your preferences are, and anticipation, that saves time in the operating room, and that allows for, I think, better outcomes. So everyone's working together, trying to do things as systematically as possible. It's the best. I wear a headlight oftentimes, and so to me that's very helpful, just to get the visualization, the lighting at all times. So I usually put loops on, put my headlight on, turn the light on, check it at my thumbs, make sure it's proper. And to me, that's like a player getting ready to
LeBron James throwing
yeah, that's kind of like my thing. The washing of the hands, it's very ritualistic, but it's required, for safety. But that's about it. Just make sure that everyone's on the same page and setting the mood for a great day. Some things that bother me are like medical TV shows that are so off about operating room stuff. Is there anything that really grinds your gears as far as if you walk past the television and there's something medical on, especially in the operating room, that sends you into frustrations?
I haven't really watched a medical show in a while, but I feel like they're often like walking in the OR without a mask on, or they're like the patient's like head's right there, and it's like that's not real. It's a lot of it's like when they're after surgery and they're supposedly intubated, and it's like nothing really looks quite right. Yeah, what about you? It sounds like you've got some axe to grind.
Sounds like I've got some demons here. No, like they'll use a suction as like the airway, and can't they just hire a medical expert for a very prominent show and just like have it taped more securely? And I feel like there's always codes and problems and paddles being going on, and people being cardioverted, and I think that while that sells and it's helpful for to keep the viewers' attention, that's not the reality of day in and day out. Like, I'm on the quality improvement committee of my surgery center. We do 12,000 cases a year, and we have very, 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 very few issues, and so it's a safety belts and suspenders passageway that you have, where everything is checked, triple checked. There's well-qualified people working. There's safe people doing their job. And I think that that's just something that people come in and, they're like, asking about, how many times somebody, has, medical issues for these problems. And I say for most of the time, we're just dealing with skin and fat. Like, we're just moving some skin and fat around. It's not open heart.
That doesn't sell. That's not a sexy TV show. Yeah, no, you're absolutely right, though. I mean, they're trying to make it exciting, and fortunately, I want my surgery day to be relatively boring, right? Like, I want everyone to have lighthearted OR where everyone can talk and we're working efficiently as a team, but it to go A to Z very smoothly, just like I have it planned in my head. Nice boring case is the best kind.
Routine. Very routine. And so, at the end of that routine case, we, maybe take some final pictures for the patient, put on some glue and tape and pads and binders and surgical bras. And then what happens to the patient? Where do they go once the magic happens?
So once they're, extubated or kind of emerge from general anesthesia, they're then transferred back to the recovery area. And your surgery center is a lot larger than ours, so you probably have 2 separate bays, but they go to the same room they started in. That's where they kind of recover and then do their the post-op, the whole kind of thing. And they have their dedicated nurse that kind of helps them wake up, make sure they're comfortable, give them extra pain meds as needed. When they're feeling up to it, they can sip some water, maybe have a snack, go to the bathroom, walk, kind of make sure they're ready to go home, go over all the instructions with the family member. Kind of normally for a lot of surgeries, shorter ones, that can be 45 minutes to an hour. Sometimes if it's a longer case, maybe hour and a half, but typically doesn't take too long until they're ready to go. I'm sure you guys have a second stage in there, the PACU first.
Yeah, we have PACU for general. We have a phase 2 that they'll be transitioned to. So usually I'll go talk to the family member or call them if they're running errands and getting meds and, handling the kids and so forth, but let them know that everything went great. And then, our PACU and phase 2 nurses are phenomenal. They're different phases, but we constantly get compliments from our patients as far as just how sweet and helpful they were. And, that's really when the patient's most vulnerable is, they're sore, they're achy, they're, nervous, and, they need help. They need help getting up and moving around that first time just to give them that confidence. And so that's important to have. And was able to build up the plastic surgery practice of my career over the last several years. So they're very well equipped and educated to know about the common discharge instructions and things to do, things not to do. And there's just fewer and fewer questions. And oftentimes I'm finishing my second case and walking out and they're saying, oh, wow, the first one did great. She's already out of here. And so that's just the way that it works. We chose a specialty that allows for many outpatient procedures in and out the same day, going home feeling good, feeling excited, not hospitalizations and admissions and really scary stuff most of the time, which is great, and able to be part of the team for our patients. Yeah.
And then after surgery, they go home. I don't know. I tend to check on my patients the night of just to, make a check, and they don't probably, I don't often see them right after surgery because I'm often back in the OR with another surgery, but talk to a family member, but I like to just touch base the evening after or evening of to make sure they're feeling good and answer any questions they might have. And then another team member checks in. So we often tell them there's lots of checkpoints. We're not just, waiting to see you at your recoveries, and we're always available if things come up. So fortunately, these do go very smoothly, very low kind of risk of, real complications. But you also want to be on the lookout for things. So, what else? What did we miss?
I think that was a quick flow through chart of checking in, registering, getting set up preoperatively with IVs and anesthetics, meeting the circulating nurse, heading back to the OR, drifting to sleep, safely and sterilely allowing the surgery to occur with our team members that each have an important role and function, transferring to the post-operative unit to be discharged home and to begin their recovery. And investments is not just the surgery day, but the recovery phase. And that's important. And whether it's calling them that night, the next day, seeing them frequently, making sure that, their questions are answered and they're feeling good. It's a rewarding practice that we're both very lucky to be a part of.
Yeah. All right. Well, another great, exhilarating episode.
Case closed. Yeah. Music in the OR is okay. And in small doses, keep changing up the playlist. And I'm glad you got 60 hours of music that you have.
So it's got to be 75 by now. It's a long playlist. Every once in a while a song kind of comes on too often and I have to go delete it. But just keep tweaking. All right. Well, we'll talk soon. Good luck with the hockey.
Yep. Thanks, man. See ya.
Yeah.
Thanks so much for tuning into this week's episode of Fuller Butz, a behind-the-scenes plastic surgery podcast. Doctors Fuller and Butz are so appreciative of your time and attention. We invite you to subscribe, share, and continue to enjoy our plastic surgery perspective. Feel free to reach out on Instagram at either @SFullerSurgeryMD or @DanielButzMD. That's Butz with a Z for comments, suggestions, and support. Remember, be artsy, stay scientific, and make life fun. We hope you'll join us again on the next episode of Fuller Butz.